All right, folks, are we ready? Yes? Fun yes, at least. End of term, everyone's busy, stressed out. Me too. So just the housekeeping for this class. This will get posted. It's not posted yet because I just did it. Quite a few questions about your pitch presentations, especially for the groups that have online and not online components. Basically, you're free to do what you want. So you can use any format you want. If the whole pitch presentation is a video, that's fine. If you know, half is someone talking online and half is people speaking in the class, that's also fine. The format is yours, basically. Okay. There's still the guidelines. It's about a 15-minute presentation. Everyone has to participate, and you have your sort of rubric of the elements that you have to hit. But other than that, the format is yours. Okay. So feel free to, you know, be creative and do whatever. Okay, so final report out of question today. Are we expected to discuss how the data will be analyzed, statistical software, methods of analysis, statistical details in the evaluation section? My answer is it's your group's decision. It's not completely necessary, but it's informative for replication. So if you've met with me, if your group has met with me, one of the things that I've hit on is sort of to say, if I was going to take this report, your final report, and implement it somewhere else, would I have enough detail to replicate the intervention that you're proposing? So some elements of that analysis would be interesting for replication, but you don't need to go into a crazy amount of detail. Again, as I mentioned to the groups that have met with me and to the groups that haven't, you'll get the little spiel soon enough. But a crucial piece of the puzzle for getting a better mark is the decisions that your group makes around what goes in and what goes out, because I know that the space is limited, and that's part of the point of the assignment. So as a group, you need to make decisions around what goes in and what goes out, and sort of the more relevant and the better decisions are made around that, the better mark you will get. Okay, so those are sort of crucial aspects. So the answer is, it's probably important to include some of this, but do you need 500 words on this? No. And that's where the decision is going to be up to your group. Okay, so a little summary on the Data Blitz presentation. So everyone's gotten their mark. Again, the mark is the average of my mark and Tamara's mark, except in a specific case. I'll talk about that in a second. If you want to see your breakdown, we'll send you the 2 marking rubrics that each one of us filled out, and you'll see whether there's a discrepancy or not. Overall, the presentations, I think, were well done. Most of the required elements were included. So if you had whatever the thing in the marking rubric was, you automatically got 0.5. But then to go from 0.5 to 1 was sort of to say, okay, did you present it well? Did you make the case for it? Was it interesting? All of those kind of elements about the presentation style, and not only was it in there or not. I think overall the presentations could have been more practiced. Okay, I'm not sure if they could have been more practiced, or lots of people just needed to like let go of the safety net of having something in your hand. But a lot of people still had a paper in their hand, and I'm not sure whether they actually needed the paper or not. So I guess my kind of advice is like, to do this again, just cut the safety net. Don't have the paper, and see how it goes. Okay. And you'll sort of realize maybe I should have practiced more, maybe I should have practiced less, but it gives the impression that you have practiced less if you have a paper in your hand. I'll tell you that right now, right? If you have something here, if you have a laptop or whatever, even no matter how much you practiced, it just gives the impression that you practiced less because you have the safety net. Okay? Does that kind of make sense? And then I guess the last take home, I mean, you saw all of the other presentations, okay? Really great presentations are extremely difficult, and they take a ton of time, okay? So that's just something to remember and think about, you know, the next time that you have some really important presentation to make. How much time do you have to practice? How much feedback do you have to get from other people? That kind of stuff if you want to do a really good presentation or have a really good presentation, okay? So your marks, the average was 75. The average difference between my mark and Tamara's mark was 3.5%. Okay, so the marks are highly correlated. They're usually within 0.5 of each other. or 0.5, that's 5%. So they're less than sort of one tick, one side or the other on the marking rubric. Except in two cases, or in any case, I guess, where the marks were more than 20% different, we took the highest mark and gave that person the highest mark. So there was two cases of that, basically. So, for example, if I gave a student a 5 and Tamara gave them an 8, they would have gotten an 8. Okay, they wouldn't have gotten whatever the average of that would be. Okay, just because we're trying to sort of acknowledge that for some reason there's a really big gap between our marking, and typically there's not. So give the student the benefit of the doubt and give them the higher mark. Does that make sense? Questions on that? Yeah. Basically, the argument is that what we're trying to say is that the average score is close in almost all cases, except for specific instances. So, like you'll vary by 3.5%, whether we take the highest or lowest is basically the argument. So we're trying to say, okay, well, overall they're really, really close, but in certain cases there's a big discrepancy, and we're trying to acknowledge that discrepancy. So overall, your mark's only changing by 3.5%, which at the end of the day is 3.5% of 10%. So it's not a huge amount. So we're trying to sort of acknowledge that overall our marks are really highly correlated, but in certain instances, for some reason, they're just not. And this is sort of the challenge of marking and measuring and all of that kind of stuff. Does that make sense? Okay, so a couple more comments, I guess, on your short report. Your short report, and then moving into your long report. The groups that I've spoken to already, you will have got this, but you'll get it again. So a key component moving forward with your final report is, I know most of the groups have really sort of focused on specific people writing specific sections and then bringing that together. And as I mentioned before, that crucial piece of the puzzle is the decisions that your group makes around what goes in and what goes out. And the more quickly and the better you can sort of forget about this is my section and this is your section and so on, and just consider the report as one entity and really try to make hard decisions around what goes in and what goes out, the better you'll do, okay? So that's sort of a crucial thing about that. Forget about my section, your section. We got a bad mark on this part because you did it, whatever. That's got to go. And what has to happen is the report is a document in itself, and your group needs to like start thinking about it in that way. Okay. Other things, detail about the intervention. So as I mentioned, generally specifics are better than generalities. So if you put a comment in there that's sort of really general and you read it and you think about it, try to add some more specifics to that, especially on the intervention. What specifically are you doing with your intervention? What are the components? How are they delivered? What do they look like? That kind of thing. So you can include appendices if you want. Those don't count in your 3,000 words. Lots of groups last year had logic models, all kinds of different stuff in an appendix to supplement your written text. Okay. I've finished formatting. I mentioned to some of the groups. I've basically done two things. On Blackboard after class, I'll post basically a template for you to fill your report in. So it's all pretty, and there's like school of public health, and you've put in your title and author, and there's columns and whatever. So basically that's the template for you to submit your report with, so that we have a standard sort of formatting across all of the groups. It will work fine if you use a reference manager or anything like that. So I'll post that on Blackboard, and your group can go and get that and just start using that as your template for your report. Last thing, at faculty meeting, what day is it? Last week, I guess Friday, we had a chat about academic misconduct. So this is just a little reminder to everyone. about your responsibilities around academic conduct. I'll click on this. And this is sort of the key component here. All of our definitions of what academic misconduct is. False or misleading information, presenting the work of someone else's as one's own, blah, 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 blah. This should sort of go without saying, but it seems we need to say it. So anyways, it's just a reminder. At the moment, the school is working on getting some type of document verification program like Authenticate. I don't know if that will be in place before the report, before you submit your reports, but if it is, then your reports will go through that authentication system. So just so you know that. I'm not sure. They're in the process of getting one, but I'm not sure which one it is, and I'm not sure if it will be implemented in time for the short reports. But regardless of that, I think like the main point for me is your content should speak for itself, and I'm hoping that in this type of project, it's a little bit harder to copy paste because I'm looking for, you know, justifications and interventions and really integrating lots of different information rather than just presenting something. That being said, it's not impossible. Questions? Okay, now that's over with. We can have class. So we're talking about social inequalities in health today. This is a big class. There's a lot of content, and there's some discussion points, but I'm really hoping that, I know that lots of you have an interest in social inequalities in health, and I'm hoping that lots of people will sort of just chime in and say, hey, what about this? What about this? I've been thinking about that. And we'll kind of go through and talk really broadly about this topic. As you know, this can be a whole class. So there's some things that I might just say, we may not have time to discuss that, or, you know, go read this, or I might direct you somewhere else. So quick overview. What we're talking about today, talking about inequality and inequity, explaining health inequalities, measuring health inequalities, quantifying difference, poverty, and socioeconomic gradient, action on health inequalities, and some conclusions. So have you all had your inequality, inequity differences bashed into your head enough? So what's inequality? What's inequality? And Chu.
So equality or inequality is just the fair share of resources or unfair share of resources, or just like, and inequity is really dependent on like a person's situation. So like the resources doesn't have to be 50-50, it could be 75-25, but it's dependent on what that person has or the contextual factors.
Okay, good. That's pretty close. So this is from the Kawauchi paper that you, oh, sorry, go ahead. Go ahead.
Inequality is when there's differences or variations between two groups, and then inequity is when there's the unfairness between the two groups. Good. Okay, so that's closer to what we think about this. So inequality basically means difference, variation, disparities between one group and another group on anything. It can be health, it can be, you know, body size, it can be anything. It just means there's some kind of difference. We don't place any judgment on that difference, we just say there is a difference. Then when we talk about inequity, we talk about those differences being unfair or unjust, and we think we need to address that in some way, right? We want to do something about those differences. So again, an inequality is there's just a difference, and an inequity is there's a difference and we think that difference is unfair or unjust, and we want to do something about that. So then the next question is, like, how do we know something is, we have a pretty good idea how to measure differences, right? We've taken biostats, we kind of have a handle on that. But then when we have a difference, how do we know whether it's
inequitable? How do we know whether we should do something about it, or how do we know whether it's unfair or unjust? Any hints? I say like all the blonde hair people automatically get a 60 in this class. And all the darker haired people, all the black haired people get a 90. Is that unfair? Do you react to that in any way? It's not the greatest, says the blonde hair. Yeah, we won't listen to her. But why do you react to that? Why do you think that it's not fair? Okay, so but more deeply, that would be inequality, right? That's inequality. One group has more than another group. But why is this specific example unfair? Why do you think it's unfair? Okay, so hair color doesn't determine anything.
Well, I mean, you can dye your hair, but you can't really control your hair color.
Okay, so you can dye your hair, but you can't really control your hair color. Okay, so maybe there's some aspect of like how much control we have over something. Okay, we'll talk about that a little bit later. So, anyways, most of the research on this basically says that it's relatively simple to talk about inequality, but what distinguishes inequity is what we consider as our values and our morals and our principles in society. So we might say, for example, that it's okay that, on average, men tend to be bigger than women. That's inequality. But we don't think that that's unfair or unjust because that's kind of biological. But we might say, well, it's not fair that blonde people get a 60 and everyone else gets a 90 because we have values of fairness, right? Or we have values of individual expression, or we have values of some other aspects of our society. Here's a whole bunch that I just put up. So fairness, diversity, inclusion, democracy, individual independence, sustainability, health. These are all values that are going to sort of lean us in one way or the other to say that's unfair or that's not unfair. That's an inequity or just an inequality. Okay? And these are really hard questions to answer. It's not simple to say, no, I think that's an inequity or not. Right? And different places will see it differently. If you go to the US, the societal values are just different enough that the debate is a little bit different than it is in Canada, especially on healthcare. Should you have access to healthcare? Is that sort of an inequality or an inequity? Does that kind of make sense? Yes? So when you're thinking about this, the key point is that when you're thinking about this, you're trying to think about, okay, is there a difference? Can we quantify that difference? And then after that, is it an inequity, and why do I think it's an inequity? So you're going to have a gut reaction for sure about, yes, I think it is, or no, I think it isn't. But the next step is to say, what is the value that's behind that gut reaction that's making me think, yes or no, it is an inequity or it isn't an inequity? Okay? And that's where that next level of thinking goes to say, why do I think that this is not fair? Because I have values of fairness, because I have values of inclusion, because there's values of democracy, all that kind of stuff. So that's your next level, sort of saying, why do I think this value is unfair? And we have societal debates about this. What's fair and what's not fair, right? What are some that are happening right now around our health stuff, inequities, inequalities? Wait lists? Okay. Elaborate. Mike.
I think with wait lists, you're technically just put on a list without any assessment of, like, there's no, like not necessarily an accounting for the severity or the improvement of like what the quality of life improvements would be for different people on different points of the wait list, as well as it's just a rationing system, so it doesn't necessarily account for needs at the moment. for some of us. I don't know.
Okay, so let's say that that's the case for wait lists. Then there might be some reason to say, well, that's not fair because if I'm more severe or if I deserve more, then I should be able to go up the list, right? And that's a hard question to answer. Well, do you not? I don't know, right? Other questions we have around right to die, right? Is that equitable? Does the person have the right to do that or do they not? It's all the way up to the Supreme Court, and we're still kind of negotiating what that's going to look like in Canada. Other countries have had that type of legislation for a long time, and others don't. So there's all of these different aspects of equity or inequity that we're negotiating with all the time, sort of as a society. Medical tourism, elaborate, please. No, I know what it is, but but why is it inequitable or inequitable? Why would we think it would be inequitable? Or what are the values behind that sort of get us thinking about, well, is medical tourism inequitable or unequal? What do you think? So why do those people skip the line and go get service somewhere else? Okay, you could argue that. Well, I could argue, well, great, they're skipping the line. I move up one. This is awesome, right? And then there's arguments around sort of globalization. Well, if you skip the line and go to Mexico to get your teeth done, are you taking away service from people in that country? And those kinds of arguments. So we can make all kinds of different sort of really basic value discussions around, do I think this is fair or not? But it's never clear. It's rarely all that clear. So here's a couple little survey questions for you. I should do this in a clicker thing, but that's okay. Is this inequality or inequity? Person A dies skydiving at age 40. Person B does not skydive, dies at age 80. Just write down your answer. Just take 1 second and write down your specific answer. Don't talk to your partner about it. So is it inequality or inequity? Does everyone have an answer? Remember that you kind of need to have inequality to have inequity. So if you say inequality, you're kind of halfway there, but it's either inequality, there's no inequity, or there's inequity. So who says it's inequality? It's just a difference, and we don't care about that difference. Okay, who says it's inequity? There's a difference for some. There's some reason that that's unfair. Why? Why?
It would be unfair if if they both skydive and one person dies at 40 and another person dies at 80, right? Or if it would be unfair if they both die at 80, but one person gets to skydive and the other person doesn't get to skydive.
Okay.
Right.
Okay.
So I thought it was, so I guess I don't know.
Yeah, certainly.
I was going to say that person A can probably afford skydiving and the other person maybe cannot.
Okay, so person A might be able to afford skydiving and person B can't, so they don't have the opportunity to skydive.
I would say the information provided is not sufficient enough to determine.
Okay, so not sufficient information to provide a good answer. That's part of the reason that there's not much information there.
I can afford to skydive, but I'm not about to go skydiving, so I don't know if that's a valid answer for this situation anyway.
Okay, so you can afford to skydive, but you're not going to skydive. Okay, so again, we're getting a bit distracted by adding some background information here.
Online?
Online says?
Inequality as the opportunity was not available to the person who died at 80.
Okay, so inequality because, or inequality or inequity?
Inequality.
Okay, so I might use that same statement and say inequity. Inequity because the person didn't have the opportunity to skydive. Person B didn't skydive because they didn't have the opportunity and ends up dying at age 80.
And inequality because skydiving is a personal choice.
Okay, inequality because skydiving is a personal choice. Easy.
Yeah, I think based on the information, the thing we're interested in, the event of interest is death, right? And individual A dies because of maybe, but there's this exposure that's associated with their death. It might be related, might not be related, and individual B does not do that. So it's just inequality. Based on this, we don't have anything to say whether it's fair or not.
Okay, so we don't, again, the similar argument, we don't quite have enough information to sort of get a sense of whether it's fair or not, okay? What if I replace skydiving with eats hamburgers? Person A dies eating, Person A dies eating hamburgers at age 40. Person B does not eat hamburgers, dies at age 80. Write down your answer. Think about your answer and write it down. And he doesn't die as a result of eating the hamburgers. He eats a lot of hamburgers and dies at age 40. Yes. It's exposure to hamburgers. Yeah, CVD or diabetes or obesity or something. So who says inequality? Who says inequity? Who didn't vote? This is Australia. We got to vote here.
Maybe the reason is unavailability of nutritious food.
Okay, so maybe, again, this is our access question. Maybe the person had to eat hamburgers so they didn't have access to hamburgers.
Yeah, I think without like broader context, it's harder to know if it's a personal choice to be like eating hamburgers or eating like foie gras hamburgers every day that are really delicious and it's a high quality of fat, or like do you live in a food desert where the only food options in your neighborhood are a fast food joint or like a 2-mile walk to the grocery store where you can't afford the food. So I think that's a bit hard without context.
Okay, good. Good. So this is kind of the idea here is that whether you say it's an inequity or inequality, what everyone tends to do is everyone adds context, right? It's really hard not to make assumptions about, well, they ate hamburgers, so they don't have access, so they live in a food desert, or they eat foie gras hamburgers and it's really good, or skydiving is a personal choice, or it's not. We always kind of tend to add context around these things, which really there's not much context there at the end of the day. And oftentimes you'll find in discussions around health inequalities, this will happen, and we'll talk about sort of how we explain and how we talk about health inequalities in a minute. Second question. Person A has a random genetic mutation, dies at age 40. Person B does not have random genetic mutation, dies at age 80. Does anyone have an answer? Remember, it's Australia. Get to vote. So is this inequality or inequity? Is it inequality? Is it inequity? Okay, my inequity, folks, why is it inequity?
I'm just gonna say it's inequity because it's something that the person has no control over whatsoever. Whether
Okay.
they have a random genetic mutation or not.
Okay, so they have no control, so we call it inequity.
I feel like it kind of depends. Like, if the healthcare system did everything they could to help the person, like, we tried to help them best we could and we couldn't do anything else, then I would lean more towards an inequality. But if we didn't do anything and that's why they died, then it's an inequity.
Okay, so our level of the treatment that we can offer to this person with this mutation is going to change whether we think it's inequality or inequity. Okay? Do people agree with that?
I would probably have to add in other factors to that too, because it could be whether or not this person was able to work and support themselves and died at 40, or if they weren't able to work and then they were poor, and a bunch of other factors because of that. I don't know, I'd have to add in more than just treatments.
Okay, so again, we're adding context. We're adding context to all of this stuff. Okay, good. So we'll leave that one up in the air. Here's real data from the Saskatchewan Health Region. So this one we're going to do a little bit more detail. Okay, So I'll put this figure back up. This is life expectancy at birth by socioeconomic areas in Saskatoon. In dark blue, you have the lowest socioeconomic areas. So life expectancy is about 76 years old. In light blue, you have the highest socioeconomic areas, life expectancy sort of increasing slowly over time from about 83 to about 85 years old. Again, this is real data. So take 5 minutes and take 5 minutes, get with a buddy, and think about whether this is inequity, inequality, or both, and think about why. So why do you think this is inequity or inequality? So find a buddy. There's the slide. Are they going? Oh, this is a big group. Break up this group here. What's going on? Groups of 2 or 3. All right. How's it going? No, that's okay. Just a banana peel. Okay. Okay. Good. We'll talk about that. Yep, it's good. Hi, how's it going? Right. Good. Good. How's it going?
Good.
What do you think?
I think it's inequality.
Okay. Why?
Well, obviously there's difference between the two areas, and I think the high socioeconomic status persons, they have right to get better health care.
Okay.
So they could have longer to live.
Right. Okay. So would you call it inequality or inequity?
Inequality.
Inequality. So
There's a difference.
There's just a difference, but it's an okay difference. We're okay with that. We don't think it's inequity.
I don't think it's unfair because, well, if people can earn much money, they could decide which way to spend their money.
Yep.
And they could use this money to get better health. So, yeah.
Okay. Good. 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 Okay. Let's bring it back, folks. Let's bring it back, folks. I know everyone's excited about grad ball. Okay, so who votes for inequality? There's just a difference and we don't care. We don't think it's unjust or unfair. Couple people? Yeah, online, I hear you. Did they just ding for dinging? Oh, a hand up. Okay, perfect. Okay, who votes for inequity? Oh, all right. Who, more than 2 dings, 3 dings? Good job online. Many more. Okay, so what's the crux of the debate here? There's a combination of both, okay? Well, okay, so we have to look at the individual level. So the crux of the debate is, if we look at this difference, okay, no confidence intervals. So if we had some confidence intervals, we might be able to make a slightly better judgment to say, okay, they're not overlapping or they're overlapping, just an eyeball judgment, right? Okay, that's one thing. The second thing is to say, do we think that this difference is acceptable? So, I mean, something like a 6-year difference from the lower income areas to the higher income neighborhoods, is that an acceptable difference or not? If we say no, then we automatically have to lean towards the inequity side. If we say yes, then we're kind of more on the fence of, okay, it might be inequality. Okay? So that's sort of the broader crux of the debate, right? Is that difference acceptable? Like, some people might say yes, some people might say no. I mean, do we have to have it exactly fair? Do the lowest income people have to have the exact same life expectancy if you're using life expectancy as an outcome? Or would a 1-year difference be acceptable? Or would a 2-year difference be acceptable? Right? Like, some people are going, yeah, maybe a year or 2 is okay. 6 years acceptable, is 10 years acceptable? We don't know, right? Based on this data, right? Chris is making a more sort of methodological critique saying, well, this is ecological data and we can't really make that comparison because there's ecological fallacy happening. It's not individual level data, right? True, if we redid this with individual level data, looks pretty similar, right? We can't do it for Saskatoon because we don't have individual socioeconomic data in the health admin data, so we do what we can. Any other thoughts on this?
Okay, so you asked the question, is this an acceptable difference? I think the only time it wouldn't be is if there was no statistical difference. So like if the two weren't like statistically different. But I think every group would always strive for better health, especially if you know that somebody's doing better than you. So if you ask somebody of low socioeconomic status, would you prefer to live at 83 or are you okay at 76? Like nobody would say 76, right? So in that context, I think it's never acceptable to have lower health than you probably could have.
Huh? Just wait. Tamara, Chris, Chris is getting angry here.
Yeah, so like if you had 2 people who started off as middle class and then they both had the same opportunities growing up, like they grew up as neighbors, they both knew the exact same people, and one person made bad life decisions, ended up as living in a low SES area, another person made good life decisions, ended up living in a high SES area, then I would say that's just an inequity. Like they both had the same opportunities and they both...
Just an inequality.
Or just inequality, yeah. They made their own decisions and that's why they ended up that way. It wasn't factors that were out of their control.
Okay. And then Siddiqui after.
I'd also say like it depends on the context of like what is causing that 6-year gap, right? Like if it's because everyone in the low SES status is smoking, right? And everyone in the high SES status isn't smoking, then to me that's an inequality, right? It's not an inequity. But if it's due to actual like structural factors or financing, which probably it is, then that's more of an inequity. But that's why I think it's more of like it's a combination of both, right? Because we don't know all the variables in it.
Okay. Siddiqui and then.
Yeah, so the first thing is that when we're talking about social inequity, it's basically the combination of both. So inequality and inequity. So if there is inequality, there will be inequity. So just by saying that it's a combination doesn't, like answer that question. Now over here, if you see in these numbers, the problem is not with whether a person, like is poor or rich. It's basically the things around it. It's the outcome is life expectancy. So it's not his job to maintain the life expectancy. Now, unfairness is basically in the policies and the structure and the system that is responsible for a person, whether he is poor or rich, to maintain a life expectancy. And that is basically the state's job, or it's basically the system or public health job to maintain that stuff. He might be lazy, not earning much, but that is not the answer to the solution. We need to understand that life expectancy should be maintained, whether a person is poor or rich, right? And that is state's job.
Okay, so some argument to say that maybe there's a base level of life expectancy that we should all expect that sort of the state or some organization might maintain, and then if you're above that or below, if you're above that, fine, we consider that to be okay, right? And we're sort of getting into some of the things we're going to talk about next, which is how we explain social inequalities, and we're sort of starting to talk about it, right? We're talking about, well, is there state or structural factors that are happening, or is it an individual choice that the person's smoking, or the other example, like if two people grew up middle class and they follow sort of the same life trajectory and one makes good decisions and one makes bad, is that inequity or inequality, okay? Sorry, yeah, there's a question there. And that's what we're going to talk about next.
I was just going to say, I think we have to be careful about going from this to individuals, because if we're saying that maybe it was individual choice that led them to where they are today, it really negates the impact that the environment has on you. So where you live, maybe more people around you smoke, so you think that everyone smokes, so then you smoke. Or having what kind of income you have impacts what kind of housing you can get, what kind of food you can buy, what kind of education you can get. And so it's really easy, I think, when you're looking at people with incomes to say, I think it's individual choices that have gotten them to where they are, but it also really reduces the understanding of where they are today, I think. So.
Okay, good, and we're going to talk about that. So that's exactly sort of the perfect segue into how do we explain this? So we see a difference, right? We see, like, if I put the confidence intervals on there, there would be significant difference between the two groups. We know that there's inequality, and then we have to say, okay, is there some kind of inequity happening? And then under that is, how do you explain that difference, and how does that sort of structure what you think about how we should intervene, which is kind of where Sadiqi's going. He's kind of saying, correct me if I'm wrong or correct me if I misinterpret this, but he's kind of saying there are structural factors at play, and I think that explains some of this difference, and by that logic, we need structural types of interventions to reduce these inequalities. If I said, no, it's only about smoking, and we need individual level interventions to reduce smoking, that is sort of a different level of intervention that I'm wanting to address when I'm talking about addressing social inequality. Okay, so we did that. So we're going to talk basically about four, five-ish ways that we explain social inequalities in health, okay? The first two are artifact and selection. The third is behavioral, and the fourth is structural, and we have sort of two subcategories of structural, material, and psychosocial. The first two we'll talk about, and then we'll just leave because there's a reason for that. So the first way that we sort of talk about or explain social inequalities in health is we can say there's no relationship between social factors in health. Your income doesn't explain health. Your education doesn't explain your health. None of that. They're not associated. Basically, we have sort of measurement problems, and we have methodological problems that mean that all the associations that we found are not valid. So how we measure social factors will affect our results, and that there's no association. So our arrow is no association between social factors and health. That's artifact. So basically, there's nothing there. Just an artifact of incorrect measurement and methodological problems. The second way that we can explain social inequalities in health is we can say, well, it's selection. The relationship is actually the other way around. We have reverse causality happening. Ill health causes social differences between groups. So I get sick, and as a result of being sick, I'm less able to access the workforce. I'm less able to access education, and that means that I sort of fall further down into the social ladder, and that means that when I look at an association, I say, oh, it's the social factors causing the ill health, but it's the ill health. It's actually the other way around. The ill health causes lower social outcomes. Do you buy that? Those two explanations, artifact and selection? Katie's like, yeah, I think I got it. I'm there. No? Anybody?
I don't buy it just because both of these represent like specific cases. Like it might happen in certain situations, certain circumstances, but you can't generalize and say, okay, this is how it always happens. Like health always causes social factors and differences in social factors. It might happen sometimes where say you're born with a genetic disorder. I mean, maybe you can't do certain things as well, and that leads to the social difference, right?
Okay, good. What does our past research kind of tell us about this? Correlation doesn't equal causation, okay? So this is sort of our, I mean, we could use that, you can use correlation doesn't equal causation in a lot of different cases, okay? But here would just be sort of our example of our artifact. Correlation doesn't equal causation, right? There's too many methodological problems. Or if we have a reverse causality example, okay? Basically, all of our published research has shown that these probably aren't the case, and actually they're definitely not the case. So we shouldn't really consider these, but the reason I bring them up is there's two reasons I bring them up. First is that historically in the debate around social determinants of health and social inequalities, these were important explanations that have since been sort of proven or demonstrated to be incorrect. But in sort of regular public discourse around social determinants around health and around social inequalities in health, you'll see all kinds of examples of people using an artifact explanation to say that, no, it's a measurement problem and it's another kind of problem, a methodological problem. And you'll see people using this reverse causality argument to say, no, it's the ill health that causes the social factors, the social differences that we find. Okay? So when you're hearing people talk about in sort of public discourse about social inequalities in health, you should always be sort of trying to pick out what are they using as their explanation? How does it fit in with artifact selection and the two other factors we're going to talk, explanations we're going to talk about, behavioral and structural explanations. Because that's going to give you a hint probably of what they're going to propose in terms of intervention or how they're going to think about how we should intervene or whether we should intervene. And also give you an idea of, okay, where are they going and how does that fit with what I think, okay? So our behavioral explanation, we've heard some examples of this. Health damaging behavior, smoking, drinking are differentially distributed across social groups and explain the socioeconomic gradient. So basically, lower income people smoke more, they drink more, they do less physical activity, and that's why we have social differences in health. Does everyone agree with that? Disagree with that? No one's voting. Okay, good, exactly. So it's probably going to be a combination of everything, and how we think about that is important. You'll see people sort of put the behavioral argument ahead of the structural argument, and you'll see people put the structural argument ahead of the behavioral argument. And you're right, it's probably a little bit of both. And we have our structural argument. We have two basic forms of a structural argument, and we'll get into this in a little more detail. So the basic structural argument is that social and physical environments are differentially distributed, and that explains our socioeconomic gradient, okay? And that's sort of our broad explanation. But within that explanation, there's two sub-explanations. The first is a basic material explanation. So the material explanation basically says, in these structural factors, the reason that lower socioeconomic groups are less healthy is because they actually have less material goods and access to things. They have, poor food, poor shelter, less access to health care, lower home ownership, lower access to internet, all of that kind of stuff. They actually just have less and can afford more in order to make themselves healthier. Okay? And this is, I would say that in my quick discussions with lots of the groups, this is where people tend to go, right? We tend to think, generally speaking, like, low income, poverty, they just don't have enough, right? And that's partly true, but we'll talk about why that might not be 100% the case. And then we have this idea of sort of psychosocial structural factors, okay? So these are the direct or indirect effects of stress stemming from either being low in the social hierarchy or low in living conditions, sort of your social comparisons. We're comparing each other to other people. We're saying, well, I'm poor, so I shouldn't have this or I shouldn't be able to access this. Okay, lots of people talk about it as allostatic load, just overall life stress around all of the things that you don't have and that you're maybe trying to get. So just like I said, these things aren't mutually exclusive, and it's important to think about. Okay, so we're going to do another example, another discussion. So in groups of 2 or 3, take 5 minutes. Write down as many explanations for the social gradient diabetes in Saskatoon as possible. And then is the gradient unequal, inequitable, or both? And I'll show you the gradient in a minute. Okay? And I'll sort of walk you through the gradient. So this is real data, again, from Saskatoon. The diabetes rate per 1,000 in the lowest income groups here in the quintile 2, second lowest income, quintile 3, the average sort of income, quintile 4, higher income, and quintile 5, highest income. Okay? This is our socioeconomic gradient. Hundreds of studies have shown basically this gradient. If you sort of group people by their socioeconomic status into 5 categories, 10 categories, 4 categories, you'll see this gradient kind of happen. Okay? So again, what we're looking at is what explains the gradient in diabetes in Saskatoon, and is it unequal, inequitable, or both? So we go from diabetes rates of about 25 per 1,000 to, like, let's say 2 or 3 per 1,000 in our highest income group. Ready? Go. And I'll just say, as you're going, try to group your conversation into those factors. Okay, so if you say something like you live in a food desert, well, is that a material material explanation? And if it's material, is it a biosocial explanation, or is it sort of just an income or absolute material deprivation? Is it a behavioral explanation? Why is it a behavioral explanation? Let's bring it back. Okay. What explains the gradient? Thoughts? Discussions? Bridges, are you going?
Okay, so for under the behavioral category, we have personal choices like smoking, physical inactivity, stress, obesity. Under structural material, we have employment and income, access to healthy food, access to a community center or gym, and healthcare resources. Under psychological structural, we have if you are in a lower SES group, then maybe you're more stressed, and then this may lead to multiple factors such as like weight gain, and then it's just like a domino effect type thing, and then to diabetes. For cultural, we have yeah. So these are my notes. Okay, so cultural factors.
Okay.
So, for example, if you drink a lot of chai tea lattes, which have a lot of sugar in certain cultures, and yeah.
Is that a culture or is that behavioral, drinking chai tea latte?
Well, I mean, if it's part of your culture, and let's say it's part of your culture to have tea with your parents and with aunts and uncles, things like that, then it becomes a cultural thing rather than a choice. Like celebration. So it's part of your lifestyle and socializing and things. So it may not necessarily be a behavioral choice to drink the tea, but you kind of have to.
Okay, good. So if I said that tobacco is cultural in First Nations, and the smoking rates among First Nations are much higher than the rest of the population, would you argue that same cultural argument to say that the tobacco use among First Nations is cultural practice or is a behavioral practice? How would we balance that? What? Depends which tobacco you're talking about. Okay. Okay, like how?
If you're using it for religious practices or something, then it'd be cultural. But if it's just a choice to smoke, then it's a behavioral.
Okay.
Same to kind of counter Bridget's point about the tea. It's like that could be a cultural behavior, but I mean you can also make choices to make that tea healthy. So you can still drink the tea, but you don't need to put the sugar and the milk and everything else into it, you know?
Okay, good. So do any other groups have any other points that we missed, things that they want to bring up?
I was just going to say that if you don't put the sugar and the milk in, it's not chai tea.
You don't put the sugar and the milk, it's not chai tea. So we're coming back to the cultural practices. The sugar and the milk are cultural. Okay. Okay, so anybody else, other groups? Yep.
Like structural, like access to healthy food, but also like material access to maybe like a gym membership or something like that too, also makes a difference.
Okay, so access in terms of like proximity and availability and affordability of gyms and healthcare and all of these types of things, right? Okay, good. So through some of the discussion, I kind of heard a little bit of like the psychosocial one is a little bit challenging, and I'll kind of try to explain and hopefully explain why we came up with that psychosocial one and why it's challenging, but also it's plausible. We think it's in there anyway. So a lot of the things we've talked about, whether they be behavioral practices or cultural practices or structural factors, are really easily explained, like the difference between the lowest income and the highest income, right? Like if you just don't have anything and you don't have access to healthcare and you can't read and you can't, don't know anything about nutrition, probably you're going to have less access, right? Probably going to have a higher rate of diabetes than someone who can do all those things and pay and whatever. But what explains the difference between 4 and 5? This is a consistent finding in hundreds of studies. Like, your 4 is like a nurse whose husband is also working full-time, who have 2 kids who earn like let's say $80,000 to $100,000 a year, and your 5 is like they earn $150,000 a year, so on and so on. Like, how do you explain such a consistent finding of a difference between 4 and 5? Like, seriously, there isn't an answer really to this question, but that's kind of where this psychosocial explanation came in, because your basic material explanations maybe don't fly so well in the sense that they probably have pretty similar access. What they're going to be able to afford in terms of healthcare probably isn't going to change their diabetes rate, right? It might change like their outcome if they have stage 4 cancer, but
what is considered highest income again? Like, is that like a celebrity or somebody like that? Would that?
No, this is real data from Saskatoon. So,
no, but like, what is considered highest income? Like, what is the?
This is just like it's quintile. So take the distribution of income and make 5 categories. So Saskatoon, I think the highest income category is like 90,000 plus, 90,000 a year plus.
If you're a nurse and like if you're a nurse or a doctor or a physician or something, you probably don't have. Like in my head, I was just thinking, if you have a lot of money, you probably have a nutritionist or something on hand who makes your meals and tells you what exactly.
No, it's not that high. The highest income isn't that high income. It's not like I have a chef on staff. It includes a lot of people who are much closer to like normal or average than like our really, really rich people who have a chef on staff and that kind of thing, right? It's not just that really high end of the rich spectrum. So this is 20% of the income, right? Of the income distribution approximately goes into this category. So, you know, there's really, really rich people, but there's also a good chunk of people who aren't really super rich. Yeah.
I just thought that it probably has to do with stress in the job. So people who are in have higher income, they have a higher in their job, so they have more control over their work versus somebody who's just yeah. So that's what I thought that stress would have an effect.
Okay. A couple other.
Potentially with the highest income, maybe they aren't families, so they don't have kids, they don't have to deal with that, and they can focus more on themselves as opposed to having to feed the kids and just eat whatever they can whenever they want. So they're more the Generation Xers instead of the baby boomers.
Okay. Okay. Maybe there's like maybe there's some confounding here going on by generation or family status or something.
How about sampling size? I mean, you can't have equal number of people in the highest income and the lowest income, right? Maybe having more people in that lowest income category maybe weighs it more, maybe.
Well, it's about 20% in each group. So it's just the quintile. It's just like take all the income and
income, right? Let's say, like, do you think Saskatoon has equal number of highest income people and lowest income people? I mean, each category would have like more sample allocated to that, even though.
No, each category has 20% of the population. We just took all the income distribution divided by 5. So there's about 20% of the population in each group. There's a question back there.
I was just adding to that point, like if you take the highest, the people from highest income, and we ask them if they have no stress or some, so probably they won't say we don't have any stress. So there is some, we can categorize the stress according to different types, and then we can more look into further the factors or whatever.
Okay, good. Yeah.
So we were thinking though, and like the genetic factors that put you into the highest income, and no, but like because height is related to income, right? The taller you are, the better chance you are of getting promotion, and the taller you are, then the less chance you're going to have. Like you burn more calories, you're going to be skinnier, and better looking, skinnier people are more likely to get promotions too, right? Well, I'm dead serious about it, but so yeah, and then you're less likely to have diabetes with that, right? So maybe healthier people are more likely to have more income.
Okay, so that explanation is basically that's exactly our selection explanation, right? It's saying that healthier people are more likely to have more income, so the relationship is actually opposite. right? We pretty much know that that's not the case. This is just a super basic example from Saskatoon, but lots and lots of studies show that that's probably not the case, right? But again, what but again, what we're really trying to think about here is what I'm really trying to get you to think about is two things. First of all, there's no easy answer, right? And we know that this health gradient, the gradient exists, and it's been shown in tons and tons of studies, but we still don't really know how to explain it well. Like, I can't tell you 12% of the distribution of diabetes by income is associated with behavioral factors, and this percent is I can't do that. And for all the different diseases, we don't really have a good sense of that. So this is still sort of a really wide open research area in terms of explaining the difference. And you're exactly right. The sort of stress explanation between the 4s and the 5, the highest income and the next income category, it was basically what created that psychosocial category of explanation. Basically, they said, well, it's because these highest income earners have the most control. It's not about stress necessarily, but it's about control over work environment. And if I have control, then I feel less stressed, and then I'm sort of able to deal with my life in a little bit more controlled way. That's where that explanation comes from. And then as we go down, we get more into sort of the material, behavioral kind of explanations. But there's no clear answer. And again, it's up for debate, and I appreciate like all of the discussion and sort of saying, well, maybe it's this, maybe it's that. We're not exactly sure. This is where we're at in this research. So it's not like there's a clear answer. We're still kind of up for debate about how much explains what, and we'll talk about what we need to do about it after. Okay, let's have a break. Come back in 15 minutes, so 3 o'clock, and then we'll talk about how we measure health inequalities. Okay, folks, let's get started. Okay, so next thing we're going to talk about is how we measure health inequalities. Probably mislabeled. It's more like how we measure our social factors when we're doing studies that want to look at health inequalities or social inequalities in health. Okay, so we're going to talk about sort of three broad areas: independent measures or individual measures, things like income, ethnicity; composite measures, so combinations of multiple independent measures. We'll talk about why we do that, and then we'll talk about sort of area level measures, and we'll talk about the index of deprivation as our example of that measure. Okay, so why do we need to measure this stuff? Why do we care about your income and your ethnicity and your neighborhood where you live? Is it only for health research, or do we use it for all kinds of other research? Other research? Yeah, right. We use it for all kinds of other research. Economists are going to use it. Tons of other people are going to use it to do studies of, the economy and ethnicity and race and all of that kind of stuff. So we have, I'm going to talk about income primarily in our independent measures. We're going to talk about before tax income, after tax income, individual or household income. And we're going to talk very briefly about ethnicity and education. So when we're talking about individual measures of income that are asked of people, we have a bunch of different ways to do it, okay? So we can ask people their income like this. So this is the exact question from the Canadian Community Health Survey. So the Canadian Community Health Survey is a sort of yearly repeat cross-sectional survey that's representative at the health region level in Canada. And the question that they ask is, what is your best estimate of the total income received by all household members from all sources before taxes and deductions in the past 12 months? Would you have a good answer to that question? Ballpark it? Would you be like how much error do you think you'd have? Would you be like within $1,000, within $100, within $5,000, within $10,000? You'd be within 5,000? Who says they're between 5,000-ish? It's tax time, so you might be a little bit more aware of where you are. Within about 5,000? Okay. Right. So we have some error here. We have some differences. I probably would have a way worse answer, partly because my partner is a family physician and her income fluctuates a lot based on her daily billing. So it's like, okay, well, some days it's a lot, some days it's not a lot, and I couldn't make a good average out of that. The way that they ask it in the behavioral risk factor surveillance system, so this is kind of an equivalent survey in the U.S., except they actually the behavioral risk factor surveillance system, they like drive these trucks all around the states and they actually physically measure people's height and weight and all kinds of other things. The question is really long, but they ask it this way. They say, is your annual household income from all sources? And then they just say, stop when I get to the right one. Less than 10,000, less than 15,000, less than 20,000, less than 25,000. And then when you hit the category, you just tell them to stop. Okay? Why do you think they do this instead of the behavioral risk factor surveillance? Why do they do this stopping kind of thing versus our just tell me, what's the amount? Any ideas?
I think in our culture, people are really hesitant to talk about money and income. And so if you're asking a direct question, it might be harder for people to admit the real question. But if you're asking more like in this ballpark, it might feel less invasive or like less embarrassing potentially, depending on your money.
Yeah. Okay. So we might be able to increase our response rates if we actually don't have people give a number, right? They don't even have to say a number. All they have to say is in the behavioral risk factor surveillance system, they'll all they have to say is stop. They never say a number. They just say stop. Okay. Whereas in our CCHS question, you have to give a number. You have to actually write down a number. Okay. People might be hesitant to write down a number. Okay. So we have these different ideas of how we might go about measuring income. So now if we think about this income question again from a different perspective, and we say the CCHS has a second question that's the exact same and says after taxes. So it says, what is your best estimate of total income received by all household members from all sources after taxes and deductions in the past 12 months? Would you be within 5,000? How much money do you get back, give or take? Anything? Depends if you're an accountant or not. Okay, depends if you have an accountant friend or not. Okay, and in this one they don't distinguish between before and after tax. They just say, what's your annual household income from all sources? Okay, why might it be important that we want to know about before or after tax income if we're trying to look at the association between income and health inequalities? What's the whole point of taxes? Right, so one of the points of taxes is to make people a little more equal, to give something back to people who are in need, right? And we might think that's probably going to impact their health possibly, right? Yeah.
I was just going to say people that are on social assistance don't have to pay taxes if that's their only source of income. So that could factor into how much money their actual income generates in answering that specific question. Because people that are in higher brackets that have real work experience, they're paying into the safety net, whereas people that are taking from that safety net aren't paying back into it with the money they receive from it.
Right. Okay. Right. And let's say we want to do a study on the association between income and diabetes, kind of like we did. Okay. And we use before tax income instead of after tax income. What's that going to possibly do to our results? Any ideas about that? So before tax is depending on what category you're in, your income is going to be higher or lower. If you're a low income person, before tax, your income is going to look lower, right? Because you're not getting those feed-ins from the system. If you're a higher income person, before tax, your income is going to look higher because you're not getting taxed on that income, right? So if you use before tax income, you accentuate the difference between the high and the low. And what that means by association is that you probably accentuate the difference in disparity between high and low income and diabetes. You say, oh, well, these people make this much money, these people make this much. There's more difference in diabetes. Okay? Whereas if you use after-tax income, you're sort of squashing the variation a little bit, and then you're probably getting a truer picture of what that variation might look like. Okay? So why is this important? If you read papers, if you look at discussions, if you look at different organizations or papers talking about this, these are sort of judgment calls that people know and people make decisions about when they write papers or when they publish reports. And they might say, well, before tax income, the association between income and diabetes is X, but we have to sort of keep our researcher hat on and say, yeah, but that's probably wrong because you're cheating a little bit. You're accentuating difference by using before tax income instead of after tax income. Okay? Similarly with household income, right? If we use household income, my partner contributes way more to our total household income than I do. Well, that might impact sort of my association. Am I influenced by my partner's income, and how much am I influenced by that? Okay? So if you just take my income, yeah, okay, but if you take our household income, then we go quite a bit higher, okay? Or we might go quite a bit lower depending on your partner's income. Does that sort of make sense? So the idea here is that both the way we measure income in terms of the question that we ask you, so if we just say give us a value or pick a category, and whether we say before tax or after tax or household or individual, all matter kind of in the answer that we're going to get at the end of the day. Okay, and that we as sort of researchers doing this kind of work need to really be aware of that kind of thing, these differences. Okay, so the next thing is when we're thinking about our independent measures. Okay, we're asking you, what's your income? What's your education? What's your employment status, full-time, part-time, so on and so on. If we throw these into a model and sort of try to do an analysis of looking at income separately from education, separately from employment, what might we find in our model and what might we have problems with a little bit. Multicollinearity, boom. So what's multicollinearity? Right, so when we have different variables that are probably measuring the same thing or that are highly correlated, right? So we might find that income is highly correlated with education, is highly correlated with job status, full-time, part-time, that kind of thing, okay? And this is where there's a big debate, actually, a little bit in the literature and more sort of in the public sphere about whether it's appropriate to use composite measures or measures that try to combine income, education, and employment to represent like a deprivation status or a general socioeconomic status compared to using individual measures like income, for example, or like education. So, I mean, I'm not exactly sure where I fall in the debate, to be honest. But a lot of people tend to group these things together. So we saw a couple presentations. Sadiqi's presentation and the data blitz showed the data from the spirit level book with that income in that measure of social deprivation or income inequality or whatever. That's a composite measure. It combines income, education, all of these types of things into one sort of mega variable. Any thoughts on this? Combining all the variables, putting into one big variable. So let's say I put in more things. Let's say I put in income, education, so the spirit level, I can't remember, I should maybe look it up. The spirit level indicator has like income, education, employment, ethnicity. I think it has like mother's education. It has all kinds of different variables in there. And it says this is one thing, it's all correlated. We're going to look at associations between this big variable and a bunch of other stuff. Kaylee. You don't agree? Why? Yes, you do.
When you group it all as one thing, you miss the breakdown and correlations between individual things. So they might not all be causing the correlation. It could be one specific, whatever you said, make up the spirit. One specific thing within that category that's causing the correlation and not everything else.
Okay, good. So we might, yeah, we lose some data, and it might be that income is actually driving the whole association, and by just throwing more variables in there, we're not adding any new explanatory power. We're just sort of throwing new variables in there and saying, okay, this is all one big variable. Okay? Yeah, that's definitely sort of hinges on the debate. The other part of this debate a little bit is to say, well, if we throw everything together and we know that all of these variables are correlated with each other, we're probably more likely to find a correlation with some other variable because we just have so much variance in when we throw all these variables together. Okay, so this is another big part of the debate. And if you've read like the spirit level book and then all of the rebuttals that came from critiquing the spirit level, basically a lot of them hinge on this exact question. Is it appropriate to combine? There's two hinges on the spirit level book. Is it appropriate to combine and create a mega measure? And then the second one is the United States an outlier or not? And that sort of hinges on the methodological debate around the spirit level. But if we look at a deprivation index, so here's an individual level deprivation index, which, oh, sorry, wrong slide. So this is an individual level deprivation index that was developed by Pamplon. He's a researcher from the INSPQ, the Institut National de Santé Publique Quebec, the Quebec National Public Health Institute, looking at the top 20% of men and women in terms of life expectancy using a deprivation index that combines income, education, and employment status. And basically, they find life expectancy at age 25 to be, about 10 years different for the top and bottom 20% for men, and a little bit less for women, a little bit more for women. Okay, so we have this huge 10-year difference in life expectancy. I say huge, but that is a value judgment about the difference, right? We have a difference in life expectancy based on some of these deprivation measures, and we have to decide whether we think that's inequitable or unequal. and whether we need to do something about it. Obviously, my bias is that's probably inequitable. Okay, and then the third area for measurement that we have is essentially geographic-based measures of social inequalities in health. So these can be individual or composite within these. So oftentimes what happens is that we have health administrative data. So in Saskatchewan, we have the Health Quality Council, which is over at Innovation Place. They house all of the health record data. So if you go see your doctor and you break your foot, your doctor puts in a code. It's called ICD, International Classification of Disease, that says you broke your foot, and then you get your line in that code. Okay? If you get a medication, if you go to the emergency room, all of that data goes in there. But the only socioeconomic variables we have, or the only sort of identifying variables we have, are your age, your sex, your postal code, okay, in that data. So what researchers often do if they want to study social inequalities in health using health administrative data is that they say, okay, well, we're going to take your postal code, we're going to plop you down in space. We're going to say, here's where you live, and then we're going to say, what's the income in your neighborhood? Or what's the ethnicity distribution in your neighborhood? Or what's the education level, average education level in your neighborhood? And we're going to assume that your neighborhood is representative of you as an individual. You can agree or disagree with that or not, but it happens all the time because we just don't have individual level data on the health administrative side. Often we do this with census geographies. So in Canada, who's heard of a census geography? Yeah, go ahead.
So this summer in my practicum, I was doing a public health unit scan. I'll talk about it on Thursday at seminar for anyone interested. But so the Toronto LIN, in Ontario, we have local health integration networks, which control the funding for different regional health units. And the Toronto LIN is moving into the direction of only providing full funding for hospitals and clinics that are accessing that personal level data. So who's an immigrant, who's in a different quintile of income. So they are, in Ontario, moving towards collecting that personal data so that we can better target healthcare programs. So it's kind of interesting what's going on. Yeah, and the Saskatchewan Health Region is doing something kind of similar. So that at the moment, the Saskatchewan Health Region is doing this hotspotting analysis, sort of trying to find the most heavy users of the healthcare system. There's about 500 of them, and to collect sociodemographic data on those people to see if those socio-demographic factors might explain why they're using so much healthcare, and then to address that, because I can't remember what the number exactly is, but it's something like they represent 10% of the total healthcare spending in the region. It's like crazy how much these people cost the system. So seeing if we can just address their potential social problems instead of them sort of always coming into the healthcare system. So dissemination areas. Who's heard of or worked with census geographies before? If I say dissemination area, if I say census metropolitan area, any of those types of things? So let's just go to a map here. Oh, here's a map. I'll go back. So here's a map of Saskatoon, okay? And this is showing this deprivation index, and I'll talk about that in a minute. All of our little polygons, all those little shapes, those are dissemination areas. That's how we collect data when we do the census, or when the StatsCan does the census. So dissemination areas are between 400 and 700 people, and they're supposed to be sort of socioeconomically homogeneous. They're supposed to be similar people in those areas, okay? And that's how the whole country is sort of divided into dissemination areas. And you can aggregate up to like cities. So Saskatoon is one census metropolitan area, which represents cities, for example. Okay, so let's say we have all the census data, and we want to use an individual measure. So let's take the average income or the median income in a dissemination area and assign that to a person. Or we can say, let's take the proportion of people without a high school education and assign that to everyone in that neighborhood, for example. Or we can do, again, we can do a composite measure. So this is probably the most commonly used composite measure of deprivation, they call it at the end of the day. But it combines proportion of people without a high school education, employment,
ratio, so number of employed to unemployed, average income, proportion of people living alone, portion of people separated, divorced, or widowed, and portion of single-parent families in the dissemination area, so in one of those small little blocks. Okay, that's what it does, and then those get divided into quintiles, so 1 through 5, just like we've seen. And this is what Saskatoon looks like. Red being the most deprived, the lowest income, lowest education, lowest most people living alone. Dark blue being the least deprived, and sort of the gradient in between that. Based on your knowledge of Saskatoon, does this make sense? Pretty much? Does anything kind of surprise you? This red square here? That's all you guys, that's all the students.
Oh, that's so cloak.
Yeah.
I think that there's a lot more rental facilities beside that red square that are owned by landlords that their income might be accounted for when there's really lower income people living in those households. Would that be possible?
Unlikely, because they sample the people in those. They're not sampling the landlords. The landlords would get sampled in their house, so they'd be over here somewhere.
So then why do you see what's your explanation for the red, I guess?
I mean, if you're looking at a large student population, but it's not about, it's not about ownership, it's about residence. So it doesn't matter if you own or not, if you rent, you still get counted in the census. So it's like your postal code where you live now, or your address where you live now, that they count, not necessarily your ownership of a property, for example. Anything else interesting? There's a couple little red spots that kind of stick out a little bit. Here, here, here. Okay, so these are really commonly used. So what we'd do is we'd take a map of all the postal codes and plop you down in a space and assign you a quintile from 1 to 5. Okay. I mean, I've showed maps like this of tons of different cities in Canada. I'm like, does this make sense for you based on your knowledge of the city? And everyone's like, total, makes perfect sense, right? So at a minimum, these maps have, or this deprivation index and other like it, have some kind of sort of heuristic value to say, like, people get it when you show the map. They go, yeah, this is what my city kind of looks like. Okay, so that's sort of the quick overview of how we measure social inequalities, or how we measure social factors, typically in health studies. Another thing that we could do that would be better, that's really challenging, would be to get some data linkage between our health admin data and our tax data and mash those two together and say, okay, here's exactly how much money you make. Here's a really valid estimate or number related to your tax data, and here's your health data. Let's put that together. That's starting to happen, and those discussions are starting to happen. Kind of different pockets all over the country are doing it. But because the health data is provincially administered, each province has different foibles and things that we have to try to manage to get that done. Okay, in terms of quantifying differences, the crucial thing to remember about how we quantify differences in health status is these are inequality measures. They don't tell us anything about inequity. They just tell us, is there a difference or not? So statistically, we're doing some tests and we're going over, there's lots more, and there's some in those papers that are on Blackboard. But we're basically just asking the question, is there a difference? And should we do anything about that comes to our inequity value judgments. Okay, so I'm going to talk about sort of 4 that talk about social group differences, and 3 that talk about social group differences, and 2 that talk about distribution of health status and why that might be important to look at. Okay, so here's our same diabetes data that we just saw in table format. So diabetes rate per 1,000 in 2009. So we can make a rate ratio, divide the rate of the lowest by the rate of the highest, and we say there's 10 times more diabetes in poorest compared to richest. What does this look like? kind of looks like our first step to making an odds ratio, something like that. Okay, some kind of relative measure. Okay, so we can divide and we can also subtract. So our interpretation for our rate ratio is the same as our odds ratio, 10 times more. Okay, like we've talked about, that can be sometimes be hard to interpret. So what if we subtract the rate of the lowest by the highest? Well, we can say, we can subtract the rate of the lowest by the highest and say there's 22 or 23 more cases per 1,000 people in the poorest neighborhood compared to the richest. Okay? And this tends to be a measure that speaks to people a little bit more. You say there's 22 more cases, there's excess cases compared to the richest neighborhood. We can do some fancy regression. So here's our spirit level measure, index of health and social problems. So, oh yeah, here's what our index includes. There we go. Life expectancy, math literacy, infant mortality, homicides, imprisonments, teenage birth trust, obesity, mental illness, including drugs and alcohol addiction, and social mobility. So that's everything that goes into that spirit level indicator. And here's some countries, and we draw a line. We say, is there an association there? Okay, you can see why the big debate around is the U.S. an outlier or not in the methodological debate around this book, because it sticks out quite a bit. So when we think about, especially our first two, our rate ratio and rate difference, what are we missing here in these numbers? They're both relative. We're dividing or subtracting. What if I'm in quintile 3? I just forgotten, right? We're only comparing the highest to the lowest. So this is like our extreme case. In our extreme case, how much difference is there? But, well, is there a statistical difference between 13 and 25? We can do the test, but typically we don't. Typically we just say, the highest, lowest, this is how bad it is. And that's partly because we have better measures, I guess, of how to think of the distribution of health status by income status. Has anyone heard of a Lorenz curve or Gini coefficient? So a Lorenz curve and a Gini coefficient, they're kind of the same. Basically developed by economists to look at the distribution of income in the population. So, is there a laser on? Whoa, didn't you see that? Sorry. Oh, there's the laser. So what you have here is a line of equality, and we'll see this again. So here, if income were distributed exactly equally in the population, everyone would have the same amount of income. So everyone would have, let's say, $20,000 as their annual income. What we do is we look at the cumulative share of people from lowest to highest income. So here we say, okay, here's the poorest person, and all the people all ordered, and here's the richest person. Okay? And then we say the cumulative share of income earned. So here's how much income you earn from the lowest income to the highest income, how much you earn. Okay? And then what we have is this curve, and it typically looks like this. So you have, say, let's say this is 50% of the population earns, let's say, something like 20% of the overall income, if we just did like a super really rough estimate here. So 50% of our population is earning something like 20% of our income. And then the lowest 50% and the highest 50% is earning something like 80% of the total income available in the country, for example. Okay, so this gives us some idea of how income is distributed. And then what we can do, we could calculate the area under the curve, and we can give it that a value. So a higher value represents more inequality, so more income is in the highest earners. More of the total share of the income is earned by the highest earners. So the curve goes more like this. And lower inequality, the curve is closer to the line of equality, so the curve goes more like this. We can do that for health. Kind of looks opposite though. So what we do, again, this is data from Saskatoon. We can order all the population by their level of deprivation from most deprived here to least deprived here. And then we can order the percent of a health outcome. So let's say order all the diabetes cases. We have our line of equality, and then we say, okay, let's look at red, for example. This is the diabetes data from Saskatoon. So 23% of the people, the population have 40% of the diabetes cases. That's real data. So 20% of the population, the most deprived, 23% of the population have something like 40% of all the diabetes cases. So they're overrepresented in terms of the number of cases that they have if everything would be equal. And then here, if we look at the top 25%, they have, let's say, something like, I don't know, 15% of the diabetes cases. So they're underrepresented by something like 12%. And we can, again, calculate the area and get some value. Okay? So this lets us take into account the whole distribution of the outcome from the lowest to the middle to the highest income. Blank stares. Exciting stuff, isn't it? Okay? But it's really like the basic thing that we need to think about is what we do kind of has a value, gets us into these values, right? Because if, let's say I think that this distribution of diabetes is inequitable, well, how I measure it might influence my decision about that. If I look at this, I'm going to say, whoa, there's so much more diabetes here. I think that we have to do something about this. But if I measure it with a concentration curve that takes into account the whole distribution, I might go, well, maybe it's not as bad as I thought, right? Because now I'm taking into account my whole distribution of income status and cases. Okay, so we need to think about not only the measurement that we're using, the measurement tool or method, but also how that relates to the values that we have underlying our research question, or whether we think there's inequality or inequity. So just as a sort of example, the Manitoba Centre for Health Policy in Saskatchewan, we use the same thing, has developed these cutoffs for whether we think something is low inequality, moderate inequality, or high inequality. So greater than 0.2, so it can vary from 0 to 1. Greater than 0.2 we say is high inequality. And for example, in Saskatoon, the diabetes concentration coefficient is 0.4. So it's like double what we've sort of decided is a high inequality. Okay. So again, the choice depends on, so social group differences and distributions are complementary. We probably need to use lots of them when we're thinking about social inequalities in health. But we also need to think about the research questions, hypothesis, and type and availability of data. So that example from our health records and using our census data is exactly that. We're just trying to do some research about this and using the available data to make something happen. We know that it's limited, but it's either that or do nothing. So most people choose to do that, right, despite the limitations. Okay, so here's our little task, group task. A health region asks you to examine differences in diabetes rates between First Nations and non-First Nations populations. Would you choose a social group difference measure or a distribution of health status measure? And which method would you choose to quantify difference? So would you choose a rate ratio, a rate difference, a Lorenz curve, in how you're thinking about your study? That makes sense? Groups of 2, about 5 minutes. Ready, go. And I'll come around.
Hi.
How's it going?
Yes, when I mean like we are trying to understand the question. I mean, so you've asked the question that we need to examine differences between diabetes rate in First Nation and non-First Nation, right?
Mm-hmm.
So you're asking us that whether we should consider First Nation and non-First Nation, or we should diabetic or non-diabetic patients, something like that. What exactly is the question?
Well, it's to say how much. Let's say the rate of diabetes in First Nations populations is 50 per 1,000, and the rate in non-First Nations is 10 per 1,000. How do you go about measuring that difference between those two rates? So which of the measures that we just talked about, or that I just talked about probably too much, would you use, and sort of why would you use that measure?
Okay. What do you exactly mean by social group difference and distribution of health?
So that's in the notes basically. So your measures that look at social group differences are your rate ratio, rate difference regression, and your distribution of health status measures are Lorenz curve and concentration curve. So would you pick like the rate ratio, rate difference kind of measure, or the concentration curve kind of measure? How's it going? Do you understand the question? Yeah. Okay, let's bring it back. I think lots of people overthought it for a while, and then we're like, oh yeah, this is pretty basic. So, so first let's think about the question. What are we being asked to do here? Examine differences between what and what? Two groups, two social groups, First Nations and non-First Nations. So we have a big hint about where we're supposed to kind of head and sort of what we're going to choose, right? We're probably going to choose social group difference because we either have like First Nations or not First Nations is the question we're being asked. So that's likely where we're going to head in terms of our analysis, okay? And then the second question is, which method would you use? So would you use a rate ratio? Would you use rate difference? Would you try a logistic regression or like a chi-square in a 2x2 table? Thoughts on that?
If you did regression, you could account for other variables.
Okay.
Like income between the two groups or other things like that, which could contribute more to, like if you just looked at rate difference or rate ratio, you're not capturing some other variables which could affect that difference, right?
Yeah, good. How could we do our rate ratio, rate difference, and account for other factors? Stratified, something like that. Okay, we could try to estimate our rates controlling for things like income, education, that kind of thing, and then make our rate ratio once we have an estimate that's controlled for those factors. Okay, we could do something like that. That would work. Okay, this group had a vote. They said we're choosing rate. What did you choose? Rate ratio. Okay, and basically their sort of logic was, well, it's easier to explain to people the number of times or percent difference compared to the number of increased cases. Okay, I'm not sure I agree with that logic because we know the challenges of presenting people with percentages and times greater and that kind of thing. But for this audience, for sure, that's going to be something that most people will be a lot more familiar with. So this is a really basic kind of question, but it's something that health regions will often want to know. And maybe it's not First Nations, maybe it's age categories, maybe it's male and female, but this is really sort of stuff that health regions want to know all the time. And as a group, we should be pretty comfortable with, okay, this is what I'm going to do, this is why I'm going to do it, this is kind of how I would go about analyzing it. Could I do a regression? Yes. Oh yeah, we talked about that. Sorry. Okay, so the next thing we're going to go through today is poverty and gradient. So when we talk about social inequalities in health, we kind of touched on it a little bit, but oftentimes we sort of mix in the poverty piece with the health gradient piece. And when we did our first discussion on that diabetes gradient, we talked sort of about it's probably easy to explain the difference between the most and least deprived, but it's harder to think about that gradient. So what we're going to try to do now is think about, okay, well, what is poverty and how do we define that, and then how does that differ from the gradient? Okay. Sorry. So we basically have sort of two broad definitions of poverty. One is absolute poverty and one is relative poverty. And these, again, this relates to this continuous discussion about absolute versus relative measures and needing to kind of think about both. Okay? So absolute poverty is the ability to meet basic human needs, food, shelter, and avoidance of disease. So this is really sort of abject poverty. There's not a lot of people in this group, but they're not doing well at all. And then we have relative poverty, which by contrast defines poverty in terms of its relation to the standards that exist elsewhere in society. Okay? So if we think about absolute poverty, what comes to mind? Any images that pop up in your head? I'm thinking about like We Are the World and like, you know, Ethiopian famine. That's what comes to my mind when I think about sort of absolute poverty, right? When we think about relative poverty, what do we think about? How do you sort of think about that just generally when you think about that? What does a poor person in Saskatoon look like? What do they have? Are they homeless? Don't know. Where do they live? So what neighborhood they live in might give me a hint. Okay. Do they have a car? Do they have a phone? Probably. Okay. And this is where this relative poverty question is sticky, because it's by definition it's in relation to the standards that exist elsewhere in society. Okay. So there's lots of different ways of how we measure relative poverty, but as a base standard, I would say if you can't afford a cell phone, you're probably pretty poor, right? Cell phones are super cheap, and lots of people have them, and they're really, really important for accessing lots of different kinds of things. So you probably want one in order to access things, right? I have like, I live in Riversdale, and there's like the guy that comes and knocks on the door that washes my windows to get money to like go get his meds. Well, he has a phone. He like takes out his phone and he's like phoning people and whatever, and that's okay. I would probably put him in I would definitely put him in the relative poverty category. Now, if he has a car, I don't know where he lives, but does he have a car? Is he still in the relative poverty category? Well, what kind of car is it? That kind of thing. So what we're going to talk about a little bit is some measures that we use for relative poverty and absolute poverty. So there's the market basket measure. Has anyone heard of this before? So basically what the market basket measure is it's kind of like, think about, okay, I'm going to the store and I'm doing my tasks of daily living. How much does that cost, and what's the proportion of those tasks of daily living in relation to my total income? So here it says, okay, how much does it cost for me to eat a nutritious diet based on Health Canada guidelines? How much does it cost me to buy clothes and shoes? How much does my rent cost me? And how much does my transportation cost me? And if I'm above a certain proportion of my income just spending on those basic needs, then I'm in poverty. How might we think about this being good or bad? What's a nutritious diet? How much does that cost? What goes in there? Okay, what goes into clothing and footwear? What's appropriate in terms of shelter? What's appropriate in terms of transportation? Is that like I have a bus pass, or I have a nice car, or I have a bad car? You know, we can debate kind of what goes in there, and that's always what, again, is going to come up in these sort of poverty questions, is what goes into how we define whether someone is poor or not. You can get more detail, there's a link there. The other super common measure in Canada is LICO, so it's low income cutoff. People have heard of this? Yeah. So we can either have like an absolute cutoff or just a standard cutoff. So let's say $20,000. If you don't make that for household income, you're poverty. Okay. LICO tries to do that in a little bit better way, I would argue. So it's a threshold below which your family will likely devote a larger share of its income to the necessities of food, shelter, and clothing than an average family. Okay, and it's based on your census metropolitan area, so what city you live in. So it tries to take into account the fact that living in Toronto is way more expensive than living here, for example. and this is what it looks like. So here's the distribution of income and the percent of your income that you spend on your average sort of household goods living. Okay, and if you're over 20 percentage points, you hit that LICO. So if you spend more than 63% of your income on your household goods, then you're considered to be low income, depending on what city you live in. Okay, and whatever we could argue with that. The average in Canada is about $21,000. So that's if you make less than $21,000, you're considered low income on average for all of Canada, and then it varies by city and so on. People, what do you think? Everyone's like, damn it, I'm low income. It's okay, it's going to change over time, right? But what do people think of that? $21,000. It's minimum wage, roughly. In Saskatchewan, it's minimum wage. If you made a little bit under that, basically the question is, do you think these people are poor? Do you think if you made $21,200, are you poor? Is that poverty? According to this measure, yes. But according to sort of what you think and so on, are you poor?
It also depends, like, if you're living alone versus, like, if you're living with a family.
Yeah,
I mean, like $21,000, like, if you're living alone, like, you know, it's not great, but it's not horrible either. But if you have to take care of, like, a few children or something like that, then it can get really strained.
Yeah, and LICO also accounts for that. Yeah, number of kids and stuff, yeah. What do you think? Maybe? Yes? No? Anyway, no debate, but sort of this is the question that we always ends up coming up a little bit. Most of the time when you see these like low income measures, the number is going to be around $20,000. Okay, might go up to 25, might go a little bit lower, but our number is usually something like that, and it's obviously increasing with inflation. But there's debate about, like, are you actually poor if you make this much money, and what do we consider to be poor in a relative sense? In an absolute sense, probably these people aren't poor. They probably have an apartment, probably have a bus pass, they probably have a car, they definitely have a cell phone. Like, in an absolute sense, they're probably not poor, but in a relative sense, do we need to intervene? Do we need to give them more money? Do we need to sort of try to help them improve their income? Okay, and this is where, you know, big debates happen in terms of what your standard of living looks like based on how much money you make. Okay, so that's our sort of poverty question, right? We have different ways to measure it, and they're really sort of fraught, and different, what we put in really matters, and we still don't know, like, are you poor or not? It depends what you think about it. And then we have this socioeconomic gradient that we kind of talked about. So socioeconomic gradient refers to worse health of those who are at the lower levels of socioeconomic condition, and even those who are already in a relatively high socioeconomic group. So that's exactly what we saw with our diabetes thing. High income 5 is just slightly better than 4. And then 3 is just slightly worse than 4, and then so on and so on. So here's our Whitehall study. Who's heard of the Whitehall study? Who's heard of Michael Marmot? So Michael Marmot is probably the father of social inequalities and health research. Did this Whitehall study looking at coronary heart disease and social economic position. So they categorize people in the UK as administrative, professional, clerical, or other. And here's our exact gradient. This is from the study published in '78. Okay, so we can see here that for stratified by age, 40 to 49, 50 to 59, 60 to 64, we have this gradient in coronary heart disease mortality in 7.5 years by civil service grade and age. So here again, we have sort of CHD mortality percent. As your status goes up or status goes down in the socioeconomic status, your death for coronary artery disease goes up from 0 to 41%. That's a lot. And then we have the same gradients with diabetes data for Saskatoon. Okay, and the point that I'm trying to get across here is that when we're talking about social inequalities in health, we kind of need to try to think about the poverty piece and the gradient piece kind of separately, but kind of simultaneously. Because it's really easy to do this and jump from here to here and say, okay, these people are obviously different because of this. But it's really hard to explain this difference or this difference or this difference between one and two sort of categories. And we're not really sure where the research isn't really clear on that. So here's a question, 5 minutes, 4 or 5 minutes. Should we use relative or absolute measures to compare low income or socioeconomic gradients between countries? So if we're studying, for example, like between Canada and the US, or if we're studying, India and Pakistan, or if we're studying Canada and Zimbabwe, how do we compare? How do we try to make reasonable comparisons between countries on socioeconomic status? Ready, go.
we can talk about that, but I think like the initial thought is that if you want to compare, if you're comparing like homogeneous countries that look very similar, you might get away with using an absolute measure like average income or median income because they're going to need employees across those countries, right? So you might have a chance of using an absolute whereas exactly like you said, like 25 cents here versus 25 cents in other places, the purchasing power is so different that, they're not even compared, not even close to being compared. That helps. Talk very good.
Okay, let's bring it back. We're almost done. Okay, so thoughts? Relative or absolute for between country comparisons? Relative? Okay, I think most of the groups got around to relative, okay? And why might this be the case? Well, here's sort of an example. Our world extreme poverty threshold is $1.25 per day. Okay, so if you make that much money, you're in extreme poverty worldwide. The equivalent value that I kind of back of a napkin calculated in the US would be $32.2 per day. So if we said in the US, if you make $1.25 per day, you're extreme poverty. Well, in the US, if you make $1.25 per day, you're definitely in extreme poverty, but it's probably more like $30, $35 would put you in extreme poverty. And you can think about that, right? Like $30 to $35 a day is not much money. Probably sit at the Midtown Plaza and play guitar and make that much money. Oh, I'm really good at guitar, guys. So if we're thinking about these within country comparisons, so if I want to compare within Canada, I have some variation in sort of my cost of living and that kind of thing, but I can probably account for that, and I could choose to use an absolute or relative measure. So I could say like $20,000 is my cutoff for low income, and that's it. I'm just going to use that. Or I could try to use some other measure that might try to look at relative income. Between countries, it's probably pretty important to use a relative measure. It is important to use relative measures because a bunch of reasons, like you mentioned, that sort of main one is the purchasing power kind of question. But the other thing is data quality differs. When the census or the broad sort of population surveys are done, which year they're done in differs, whether they're done differs, and our measures differ between countries. So we might not have the exact same measure, so we might have to try to cobble something together to say, okay, well, Canada's LICO is kind of like the UK's some other measure that they have, and we can't exactly figure out how to combine all of those things. So the last thing we're going to talk about is action on the social inequalities in health, or social inequities. So assuming that we see differences, and assuming that we want to do something about them, well, what are we doing? And what does that kind of look like in terms of where we're at? So we're going to talk about Millennium Development Goals, WHO Commission on Social Determinants of Health, and upstream, sort of two international examples and one kind of local example. Millennium Development Goals, what are those? There's 8 of them, and there's a bunch of sub-goals. Do people know where we're at in terms of our Millennium Development Goals? Okay, so in 2000, the international community got together and said, okay, we want these development goals for the new millennium, and we want to track progress. We want to try to measure how we're doing on these goals. Okay, there's 8 broad categories, and within each category, there's kind of subcategories. You can see there where we're at. Overall, we're not doing so well on some indicators, particularly some of the maternal health and some of the maternal health and quite a few of the child mortality ones we're doing reasonably well on. Okay. But to me, if you look at these, they don't say social inequalities in health, and they don't talk really about that in their lead up. But if we look at these categories, eradicate extreme poverty and hunger, reduce child mortality, improve maternal health, combat HIV, AIDS, malaria, and other diseases, to me, those are really, at the end of the day, they're sort of social inequalities and health questions, right? We're trying to address these differences in health outcomes for kids, for mothers, and for different diseases between countries and within countries. Okay, does anyone know what's happening next with our Millennium Development Goals? We know we're not doing great, broadly speaking. What's happening next, actually this fall? We're doing it all over again. Okay, so they're not going to be called the Millennium Development Goals. I don't know if they have a name yet, but we're sort of setting new targets and reevaluating those big international goals to say, okay, can we make progress on these indicators, and do we want to pick new indicators? Skip that. Who has seen this? Closing the Gap in a Generation. This is a big report done by WHO and a special commission that was chaired by Michael Marmot, whose original work we saw, called Closing the Gap in a Generation. And basically, for their sort of intervention component, they talk about 3 broad categories. They talk about, and this is globally, they talk about improving daily living conditions, tackling the inequitable distribution of power, money, and resources, and measuring and understanding the problems and assessing the impact of action. Okay? So when we think about improving daily living conditions, that's like our foundations of public health kind of intervention, right? It's sanitation, it's housing, it's all of those basic public health interventions that lots of the developing world doesn't have, but specific subpopulations, particularly First Nations, don't really have either in Canada. And then the second thing that I think we should really focus on quite a bit as public health practitioners is measure, understand the problem, and assess the impact of action. So this is kind of our job, right? It's kind of to say, okay, we did this intervention to help mothers be healthier. We did this intervention to reduce, I don't know, what groups did I meet with today? To reduce groups, what? FASD. We did this intervention to reduce FASD in kids in Saskatchewan. But we need to measure and understand what we're doing and whether it's working or not, okay? And preferably not with before and after studies. And the last is Upstream. Who's heard of Upstream? So Upstream is kind of a new startup in Saskatoon. Oh, there's a hand. And we'll just watch their promo video. So it's kind of led by Ryan Miley, who's a physician, and their policy director is Chuck Plant, who's a sociologist, PhD student at McGill. Just gonna copy this. No.
You're standing on the edge of a river.
Promo video.
All of a sudden, a flailing, drowning child comes floating by. Without thinking, you dive in, grab the child, and swim to shore. Before you can recover, another child comes floating by. So you dive in and rescue her as well. Then another child drifts into sight. And another, and another. Eventually, hopefully, some wise person will ask, who keeps chucking these kids in the river? And they'll head upstream to find out. Every time we have to clean up an environmental disaster, every time a young person winds up in jail, every time people have to take medications to make up for the fact that they couldn't afford good food, we're suffering from the results of downstream thinking. Thinking upstream means making smarter decisions about what kind of country we want. What better goal could Canada have than creating the conditions for all people to enjoy true health and experience physical, mental, and social well-being? It's the best way to measure our success, and upstream thinking is the way we get there. Help us make the mainstream look upstream. Visit us at thinkupstream.net to find out more.
About you in that little blurb, that little video. Anything at all, especially around the language that they use. Physical, social, mental well-being. What does that sound a lot like? What? WHO definition of health, right? They also talk about the conditions for people to enjoy, to have that physical, social, and mental well-being. So we have a hint by the language that they're using that what they want to address in relation to the social determinants of health is structural factors. They're not so worried about behaviors. And we have a hint that they sort of believe in this WHO definition that health is more than the absence of disease and its complete social, physical, mental well-being, right? So we can kind of take a guess from the language that they're using where they're probably going to position themselves and what that's going to look like, okay? Why do I think that's important? Well, because this whole sort of talk on social inequalities in health and social determinants of health gets us thinking about the measures that we use and how we use them, but also how we think about and how different groups or different organizations or ourselves think about what the determinants are and how we might intervene to change them. So if we can sort of step back a little bit and think about ourselves and then step back and think, okay, what type of explanation is this organization or this person using to talk about social inequalities in health, and does that sort of fit into the values that I have around social inequalities or inequities, and how do I unpack that from an academic perspective, like, okay, well, fine, this is this is a behavioral explanation or this is a social explanation. How can I think about that? Does that kind of resonate a little bit, right? And like my challenge now for you is to go out there and like watch the news, listen to people talking about social inequalities in health, listen to the news reports coming out, and just think about the language that people use when they talk about it, and think about what types of explanations are they using? Are they mixing up sort of poverty with the health gradient, which you see all the time? And how do we sort of talk about this? And maybe how can I think about talking about it in a little bit more rational, logical way? Okay, so that's sort of my challenge to you, and especially as a little reminder, if you haven't started your reflections yet, time is running short, and this might be a good time to do the reflections. I think there's like 6 or 8 people who are finished their reflections, so to those people, congrats, good job, and quite a few who are on the way there. It's the people who haven't started yet that I'm worried about. If you're one of those people, please start. So our conclusions for today, inequity is value-based. Basically, we need to think about our values and why we think that something is unfair or unjust, why a difference would be unfair or unjust. The explanations that we use for inequalities matter, right? Whether we're using an artifact explanation or whether we're using a behavioral explanation or a material explanation, those matter because those influence how we think about intervention. If I just think that you have cancer because you smoke, I'm only going to talk about smoking interventions. I'm not going to talk about structural interventions. I'm not going to talk about cultural interventions. I'm not going to talk about that. I'm just going to say, we just need to stop people from smoking. Okay? And then I guess the last thing is there's lots of different ways to measure and quantify differences, and we just touched the very surface of that kind of discussion, but the papers that are on Blackboard will give you sort of a little bit more detail, especially those 2 Rediger papers where he goes through like 25 different measures of social inequalities. Questions, comments, or do you want to just go home? Go home. Okay, thanks everyone. See you. Oh, my mic died. They might not have heard that because my battery died. Okay.